Rectal cancer is an extremely complex disease, and I think we're seeing more and more a lot of the caveats in terms of the management of these patients that require a multidisciplinary team to deal with these complex issues. And there's emerging data demonstrating surgical treatment from a surgical standpoint is a lot more complex than we initially thought. My name is Evie Carchman. I'm an assistant professor at the University of Wisconsin in the Division of Colon and Rectal Surgery. So the majority of the variables affecting are related to the stage of disease. Then there also come into patient factors in terms of their desire for either a permanent bag or their, being able to utilize their anus for defecation, and then the functional consequences that can occur with that when it comes to rectal cancer. And there's also emerging data in terms of different therapies in terms of radiation and chemotherapy that also affects our surgical treatment. When it comes to rectal cancer, there's definitely surgeon variables that need to be taken into account in terms of a minimally invasive approach versus open, but looking at the patient overall, there's definitely a multidisciplinary team that's required in terms of the overall treatment plan for this patient, and then also not only the initial treatment but follow-up also. So in terms of the debates in terms of open versus minimally invasive approaches for rectal cancer, that is an ongoing debate based on a recent publication in JAMA. This meta-analysis demonstrating that maybe laparoscopic approaches aren't as oncologically sound as we initially had thought in terms of the intactness of the TME or the total mesorectal excision. Other ongoing debates are if we should be using extended lymphadenectomy in terms of improving survival, but then also taking into account the extended risk to that patient, the initial postoperative period, and also long term. There's also debates in terms of if watch and wait in terms of management of rectal cancer patients is appropriate or not. So in terms of long-term oncologic outcomes in terms of survival, I think we have to wait for that data to mature to be able to say that yes, minimally invasive approach is probably not as good as open, or watch and wait is an appropriate treatment response. And the same thing with extended lymphadenectomies. I think in terms of future directions, we need to have some more long-term data in terms of if some of the new treatment options are the way that we should be going in terms of the transanal TME. And there's definitely going to be new therapies out there in terms of chemotherapy that we'll be able to investigate in terms of improving treatment response, and then looking at total neoadjuvant chemotherapy, if we should be moving towards that treatment paradigm, and then if we actually need radiation for all of our rectal cancer patients, or if some of these patients can not receive radiation and still have appropriate oncologic outcomes, and then decrease the risk of complications that are associated with radiation therapy. I'm excited about the research that's ongoing in terms of improving our patient outcomes and also decreasing complications for this patient population.